Hello, everyone, and welcome back to our third lecture. In this lecture, we're going to take a look at some common antiarrhythmic drugs, their mechanisms of action, and their effects on both the cardiac action potentials that we see over here. We remember the fast action potential and the pacemaker action potential, as well as their effects on the QRS complex, QT interval, and various other parts of the EKG. So let's get started. Most of the drugs that we'll be talking about today can be broken up based on a type of classification called the von Willems classification. And this von Willems classification is a class system based on the dominant electrophysiological effects of the antiarrhythmic medication. In other words, what part or what ion channel does it affect, and how does that affect this action potential, either the fast action potential or the pacemaker action potential. It is important to note that medications in the von Willems classes do not necessarily only exhibit binding to those specific ion channels, but it is their class is determined by the most predominant binding that they exhibit. There are 4 classes in the von Willems classification, the first of which has 3 subsets. So number 1, class 1 agents are our sodium channel blockers. And this can be further broken down into 1A, 1B, and 1C. Our class 2 agents are beta blockers, which we should be familiar with from other cardiovascular conditions that we've reviewed before. Class 3 agents are potassium channel blockers. And finally, class 4 agents are calcium channel blockers, which you might remember from hypertension are the CCBs. Now, each class of antiarrhythmic is going to affect these action potentials in different ways based on the type of block that it produces. So we're going to go one at a time, starting with our sodium channel blockers, and take a look at how they're going to affect the action potentials that we see here on the right, and also some common side effects, contraindications, etc. for some of these antiarrhythmic drugs. Our first class, our class 1A antiarrhythmic agents, block both sodium channels and, to a lesser extent, potassium channels. Now, we will review with class 3 agents what this block on potassium channel does, but let's first take a look at how blockade of sodium channels is going to affect our action potentials over here on the right. The first thing that's important to remember is where sodium channels are active on these action potentials on the right. And if you remember from our last lecture on these cardiac action potentials, sodium channels are really present in this first initial phase 0 depolarization of the fast action potential. So here we have our sodium channels that are responsible for taking the cell from its negative potential here and depolarizing it to its most positive potential. Now, sodium channel blockers actually keep the sodium channels in an inactive state, so there are less sodium channels available to let ions into the cell, so it will take a longer period of time for that cell to depolarize. So as you see, the slope of our line has moved right, as there are less ion channels available for sodium to flux into the cell, thus making it take longer for the cell to depolarize. From here, the rest of the action potential will play out pretty much how we'd expect it, repolarization and plateau phases and all. The main thing to remember is that sodium channel blockers are going to decrease conduction in the tissue. It's going to take longer to depolarize. Now let's take a look at how this will affect the EKG and what changes we'll see in an EKG with a sodium channel blocker. Now here on the left, we're going to see our normal EKG. And if you haven't watched that initial video, make sure you go back and watch it, become familiar with it. But if we're looking at, if this fast action potential is taking place in the ventricles, this initial depolarization will start to line up right here with the beginning of the QRS complex as the ventricles are starting to depolarize, first with the septum, then to the rest of the ventricle and back up the sides. So this is our normal action potential. In the presence of a sodium channel blocker, that will increase the amount of time the conduction takes. It decreases conduction, it lengthens the amount of time that it takes to depolarize. Of course, the QRS complex, which represents depolarization, is going to take longer. So after the addition of a sodium channel blocker, we're going to see the QRS complex get wider. Now, this is a slight overestimation of what will happen, but this will let you picture this a little bit more clearly, what is happening in the cardiac myocytes. From here, the rest of the action potential will play out pretty much how you'd expect with our T wave. The main thing to take from this is that sodium channel blockers slow conduction and they widen the QRS complex. The first agent we're going to talk about in this class 1A antiarrhythmics is procainamide. Now, as a class 1A agent, procainamide does possess both sodium channel blocking and potassium channel blocking properties. Interestingly, procainamide is metabolized in the liver to a substrate called NAPA. And NAPA just stands for N-acetyl-procainamide. NAPA then goes to the kidneys. Here's our little kidney, where it is then excreted into the urine. Something important to watch out for with procainamide is that in patients with renal dysfunction, the kidneys are not working as well as they should. All of a sudden, this pathway is turned off. NAPA can no longer be excreted as efficiently in the urine, and NAPA is then going to build up in the bloodstream. This can be particularly concerning as NAPA pretty much lacks the sodium channel blocking capabilities and is almost a pure potassium channel blocker. Something that we'll learn that's concerning about that is potassium channel blockers do have the ability to cause a proarrhythmia, or an arrhythmia that is generated by antiarrhythmic medications that is known as torsades de pointes, which is a very, very nasty and fatal arrhythmia. Is definitely not something ideal. So we want to make sure that we're watching out for any renal dysfunction in patients that are being administered procainamide. Some side effects of procainamide include some hypotension when the drug is given via IV push rapidly. So we're going to see a decrease in blood pressure in those patients. Patients who take procainamide are also at risk for lupus-like syndromes, especially with prolonged use, which definitely makes this agent not an ideal agent for prolonged use in patients with arrhythmias. Some sorts of lupus-like syndromes, although I don't expect you to know these all, are pain, inflammation, swelling, stiffness in the joints here, or possibly a rash. And sometimes you could see this butterfly-shaped rash up on the face of the patient, as we see here. Procainamide can also cause some serious and life-threatening lowering of a type of white blood cell known as a granulocyte, which is depicted here with its little granules, and this is called agranulocytosis. Procainamide can also cause a marked decrease in platelets in some patients called thrombocytopenia. Two other drugs that are even less commonly used in this class 1A of antiarrhythmic drugs are quinidine and disopyramide. Quinidine is pretty similar to procainamide, but the important thing to note with this is that while it is similar, it is also more toxic, even at therapeutic concentrations. So at therapeutic concentrations, it can cause what we talked about earlier, that proarrhythmia, torsades de pointes. Quinidine can also cause a cluster of symptoms called synchonism, which is related to higher levels of quinidine in the bloodstream, but this can include things like tinnitus, decreased hearing, headache, nausea, vomiting, and visual disturbances. Disopyramide is also very similar to procainamide, but also has some significant antimuscarinic effects. For this reason, you do not want to use this in heart failure, as of course these patients already hold on to fluid, so making them hold on to a bit more by decreasing the urine output is definitely not a good idea. Any sort of benign prostatic hyperplasia or glaucoma. Overall, these drugs are not used very often and definitely less than procainamide due to their undesirable side effect profiles. Our next class of sodium channel blockers are our class 1B agents, which are more pure sodium channel blockers. The important thing to remember with the class 1B agents is that the higher the heart rate, the higher the sodium channel blocking effect. These drugs are very fast onset and also come off pretty fast. They dissociate from the sodium channel fairly quickly, and thus they're pretty useful in patients that have very high heart rates or ischemia or tissue damage due to lack of oxygen or blood flow. The first agent in this class that we'll talk about is lidocaine. Now, you may be familiar with lidocaine applied topically in other ways for various other conditions, but for cardiac arrhythmias, lidocaine undergoes very extensive first-pass metabolism in the liver, and thus you cannot give it orally. One side effect to be particularly familiar with lidocaine is that lidocaine at higher concentrations can cause psychosis. Now, some signs of this psychosis can end up including slurred speech, hallucinations, muscle tremors, seizures, but one early warning sign that you will have for this psychosis, or that you can have for this psychosis, is nystagmus, which is a repetitive, involuntary movement of the eyes, or the pupils, either side to side, as you try to get the patient to look side to side, or it could also be up and down, or other directions. The most important thing to remember is that this nystagmus, this shaking of the eyes essentially, is an early warning sign for psychosis that you can watch out for. The other drug that we're going to talk about in class 1B is mexiletine. Mexiletine is essentially in the same family as lidocaine, and it's very similar to lidocaine. But the benefit of mexiletine is that it is oral, or is orally bioavailable. Mexiletine is not benign. It does have some serious side effects, one of which is tremor. And it also has a fairly high rate of nausea and vomiting. So here we have our little stomach, nausea and vomiting. In addition to these side effects, it can cause some ataxia or an unsteady gait, or it might feel like the patient's a bit drunk. They're having trouble with coordination, and it can cause some dizziness or lightheadedness. Mexiletine is also metabolized via the liver, and as such, hepatic impairment actually fairly significantly affects the half-life. So if our little liver here is not doing too well, it will actually cause a doubling of the half-life. So we do want to watch out in patients with any sort of hepatic impairment when they're receiving mexiletine. Our last subclass of sodium channel blockers are our class 1C agents. Now, unlike our class 1B agents, which move into the sodium channel fairly easily and then also come off fairly easily, these class 1C agents take longer to get into the sodium channel, but once they do, they really like to block it. They do not want to move out from the sodium channel. The first agent in this class that we're going to talk about is flecainide. Now, flecainide is metabolized and excreted both via the liver and the kidneys. And thus, in patients with severe liver or kidney impairment, we do want to be cautious with flecainide. There are some renal dose adjustments once we get below 35 mils per minute. Probably the biggest thing to remember about flecainide is that it can cause some very serious increased risk of mortality, death, in patients who do have heart failure or patients who have had a previous myocardial infarction or a previous heart attack. So you cannot use if prior MI or heart failure. There's also some evidence linking flecainide to increased risk of these sorts of death and proarrhythmias in patients who do have atrial fibrillation and atrial flutter. And we'll talk a bit more about both of these arrhythmias in our next video. As we sort of just alluded to, flecainide is known to cause proarrhythmia, specifically through reentry circuits. And our next video will look at some of the mechanisms behind reentry circuits so that you understand these. Flecainide can also cause dizziness, and flecainide can also cause visual disturbances. And these visual disturbances may include blurred vision, seeing spots, etc. Our last class 1C agent is propafenone. and similarly undergoes both hepatic and renal elimination. Of note, there are currently no recommended dosage changes for any sort of renal impairment or hepatic impairment, but you do want to use this agent with caution in patients with these types of impairment. Propafenone is also a weak beta blocker and can thus lower the heart rate and have some other beta blocking activities, although it is less than its sodium channel blocking potential. And similarly to flecainide, it does have some proarrhythmic potential. Like flecainide, propafenone is also known to cause dizziness, and it also has some GI side effects, including nausea, vomiting, and also unusual taste. The main thing to remember with propafenone and flecainide is that they can cause proarrhythmia. We really do not want to use these agents if a patient has had a heart attack or has heart failure. And we do want to be very cautious in patients who do have atrial fibrillation or atrial flutter. And we'll talk in our next lecture a bit more about why that is. Our class 2 antiarrhythmic agents are our beta blockers. Now, a lot of these agents themselves should be a review from previous cardiovascular modules, but let's take a look at the function of beta blockers in the heart. So beta blockers will mostly take their effect down here with the pacemaker action potential due to the presence of beta receptors, specifically, usually beta 1 predominantly, receptors that are present in the SA node and the AV node, which of course produce the pacemaker potential. Now, as we know, the pacemaker potential is spontaneously generated with the funny current bringing the cell from its hyperpolarized state past the threshold and triggering calcium entry here, which governs the depolarization of the cell. And normally this is an automatic process. However, this process can be expedited if we do have norepinephrine or epinephrine that's coming down and binding here to the beta 1 receptor. Norepinephrine binding to the beta 1 receptor will then, through a series of intracellular events, come over and open the calcium channel directly. So epinephrine or norepinephrine binding to the beta 1 receptor will actually cause this calcium channel to open and allow calcium ions to influx into the cell, as we see over here in the phase 0 depolarization. And this will go through a very similar process you've seen before with calcium-induced or calcium-dependent calcium release from the sarcoplasmic reticulum. As we see the rise in the calcium levels inside the sarcoplasmic reticulum, this will cause a very great amount of calcium to pour out into the cell, thus causing the depolarization that we see over here in the pacemaker action potential. So in this way, norepinephrine is able to actually signal this pacemaker action potential to happen early. So it will actually happen just slightly before this normal depolarization would, and it will increase the heart rate. Now that we've reviewed that, we can understand why a blockade of these beta 1 receptors, if we have a beta blocker come in here, it's going to inhibit norepinephrine from binding to this beta 1 receptor. We will then not have this intracellular signaling. The calcium channel will close. And this will prevent calcium from entering the cell, preventing the increase in calcium in the sarcoplasmic reticulum, and overall inhibiting the calcium-dependent calcium release. So by administering a beta blocker, you're going to prevent and slow down this early depolarization of this action potential. So what is the change we're going to see to this action potential in the presence of a beta blocker? We will see an overall slower depolarization here. And as we see, the interval between these will increase, thus slowing the heart rate. Of note, as this happens in both the SA node and the AV node, not only does the SA node signaling slow down, but conduction through the AV node will also slow down. As the firing from the SA node is slowed down and prevented from being increased, our R to R interval, or the interval from one beat of the heart, one depolarization of the ventricle, to the next, is going to be increased. The other effect we may see on the EKG is a prolongation of this time period where the action potential is being held onto by the AV node. So we may see an increase in the PR interval as the electrical activity through the AV node is slowed even further. That time frame is extended before finally we have ventricular depolarization and the rest of our action potential with the T wave. Overall, this will cause an increased R to R interval and an increased P to R interval. While we will not talk about every single agent in this class, some select class 2 agents here are metoprolol, carvedilol, esmolol, etc. Now, as you've reviewed in your other cardiovascular modules, one of the main side effects we do want to watch out for with these beta blockers is when somebody is first standing up rapidly, it can cause orthostatic hypotension. And this is due to the heart's inability to compensate by increasing the heart rate for a drop in blood pressure when standing. Of course, overall, these agents also tend to lower the heart rate by their mechanism and lower blood pressure overall, as blood pressure is dependent on the heart rate. As we saw with orthostatic hypotension, as the heart is not able to compensate for changes in blood pressure, if we have decompensated heart failure, where the heart is already not able to compensate for the decreased blood flow that it's pumping out, we definitely do not want to add another agent that can further decrease that ability to compensate for the lower blood volume that's being pumped out. So we do not use in decompensated heart failure, although these agents do have some cardioprotective effects, very many cardioprotective effects in patients who do have compensated heart failure. So the only thing you have to be careful of here is decompensated heart failure. Something else that is less common in these patients, or is a less common side effect that patients may experience, is maybe some fatigue or sometimes insomnia, but general sleep disturbances have been reported by some patients. Our class 3 antiarrhythmic agents are our potassium channel blockers. Now, if you remember from our cardiac action potentials lectures, potassium channels, we're going to look mainly up here in the fast action potential, are responsible for repolarization of the cell. So potassium channels are going to be active here in this phase 3 repolarization of the cell, and they're responsible for helping to take the cell from its depolarized state back to its repolarized state to ready it for another firing. Potassium channel blockers, therefore, will decrease the ability for potassium to repolarize the cell and will thus prolong repolarization. So in these cases, we will end up seeing this repolarization phase. The slope is going to be slightly shallower, and repolarization will take slightly longer. Overall, this prolonging of the repolarization of the cells will affect our action potential up here in the time where the cell is, first of all, contracting and then repolarizing, which is this time period from the end of the QRS complex, which is our depolarization. Then we have our plateau phase and our repolarization. So this section of the EKG will be stretched. So our resulting EKG after the administration of a potassium channel blocker, we'll see a normal P wave, normal QRS complex. And then after this, our ST segment will end up being a little bit longer as our repolarization is prolonged. And this we usually measure through our QT interval, which, as we remember, is from the beginning of the QRS complex, the beginning of the Q wave, to the end, the finishing part of the T wave. The first of our class 3 agents that we're going to talk about is amiodarone, which I'm sure many of you are familiar with. The interesting part of amiodarone is that it does contain all 4 classes of activity. So amiodarone does exhibit potassium channel blocking capability, calcium channel blocking capability, sodium channel blocking capability, and some beta blocking activity. So it does exhibit some of the aspects of all 4 classes of antiarrhythmics. Another thing that's very important to remember with amiodarone is it does have some very interesting pharmacokinetics in that it has a massive or nearly infinite volume of distribution. Due to this very large volume of distribution, it does make sense that amiodarone requires loading doses. In addition to its massive volume of distribution, amiodarone is also undergoes some pretty extensive hepatic metabolism that is rather complex and definitely outside the scope of this lecture. But the main thing that you need to remember with this is that it is metabolized to many metabolites, which many are also active, and prolonged administration of amiodarone and this whole process of production of metabolites actually leads to a progressively longer half-life with prolonged administration. This can get so incredibly long that some of the metabolites, for instance, in a patient that has taken amiodarone for 9 years, once amiodarone is discontinued, amiodarone itself can have a half-life of around 7 months, but some of the active metabolites of amiodarone can actually have a half-life close to a year, about 11 and a half months. So something to just remember, amiodarone does hang around for a very long time, especially if the patient has been on it for a while. As we mentioned before, amiodarone is a substrate for many of the different cytochromes in the liver, such as CYP2C9, 3A4, and also P-glycoprotein. As you'd imagine, this metabolism can lead to many, many drug interactions. So the main thing I would say is make sure if you have a patient on amiodarone, make sure you are checking for drug interactions. Two that I would like you to be familiar with is that it does interact with both warfarin and another antiarrhythmic called digoxin. For both of these, amiodarone is going to raise the dose of warfarin and digoxin, so we are going to have to reduce the dose of each of these agents when they are used concurrently with amiodarone. As you'd imagine, due to its incredibly long half-life and its effects on many, many different ion channels in the heart, amiodarone does have an extensive side effect profile, and for that reason, it was generally considered as a last resort agent for a long period of time. One of the most significant and deadly side effects that can happen with amiodarone administration is pulmonary fibrosis. Pulmonary fibrosis is managed by discontinuing amiodarone and administration of corticosteroids and other supportive measures, and does require routine monitoring, which includes chest x-rays, and pulmonary function tests. Now, these pulmonary function tests should be analyzed at baseline. Then they should be analyzed as long as a chest X-ray at least annually for all patients. Amiodarone is also, interestingly, about 40%, I think more specifically around 37.5%, its weight is actually iodine. And if you remember from your thyroid lectures, if you haven't seen them already, you'll see them soon, and you'll get a review of this. Otherwise, this will be something that you have reviewed already. Extra iodine can cause both hyper or hypothyroidism. Amiodarone is also known to cause tremors, ataxia, or loss of coordination, almost a feeling of drunkenness, and dizziness or lightheadedness. Amiodarone can also cause increased liver function tests, and this is dose dependent. Although of note, hepatitis with amiodarone is rare. And another side effect of amiodarone that you absolutely have to counsel patients on is photosensitivity. The reason I mention this photosensitivity is that unlike some other medications where the photosensitivity can cause just a sunburn, amiodarone is unique in that it actually causes a bluish ashen gray discoloration to the skin when it is exposed to the sun. And unfortunately, this is irreversible. So we will include some photos down below the lecture, but this truly is a bluish tint or a grayish tint to the skin in patients who take amiodarone and who do not protect themselves enough from the sun's rays. So you want to make sure if your patient is taking amiodarone, make sure they're covering up if they're going outdoors, applying sunscreen liberally, and how you want to counsel them on how to apply sunscreen, as many patients do not use it as effectively as they can, as this side effect is an irreversible process. Amiodarone can also build up into little deposits in the eyes called corneal deposits. But luckily, this is reversible with administration of eye drops such as Clear Eyes, which does have to be done frequently and for a prolonged period of time, but it can be resolved, unlike the photosensitivity. The last side effect that you definitely need to be aware of with amiodarone, and this is really more prevalent with other class 3 agents, but is the presence of that fatal arrhythmia we talked about before, torsades de pointes. As a class 3 agent, and we'll talk about in our next lecture, how these agents cause these issues, but as a class 3 potassium channel blocker, amiodarone does have the capability of producing a proarrhythmia, or this torsades de pointes. This rate is actually relatively lower compared to other class 3 agents and is really less than 1%, but still something to definitely keep an eye out, as this is a fatal arrhythmia. Our next class 3 agent is a pure potassium channel blocker known as dofetilide. Dofetilide does undergo both renal and hepatic clearance, and caution should be used in conditions where patients have reduced renal or hepatic function. Of note, with severe impairment, it's generally not recommended to use dofetilide in patients with severe hepatic impairment, and there are listed dosage recommendations for patients with renal impairment. While amiodarone had a relatively lower risk of the fatal arrhythmia, or the fatal proarrhythmia called torsades de pointes, dofetilide, even when administered, started in a hospital as it's supposed to. So first we'll write down, we should start in hospital for 3 days. But even in patients that are started on dofetilide in this way, the rate of torsades de pointes, this fatal arrhythmia, is about 1.5%. So the one main thing to really remember about dofetilide is it does have a fairly high rate of this fatal arrhythmia. This is due to the idea that it is very QT prolonging. But I want you to remember for now that you want to be cautious when you're using these agents with other QT prolonging agents. Now, other QT prolonging agents can include anything like antibiotics. These are particularly your macrolide antibiotics like azithromycin. These can be antipsychotics, or of course other antiarrhythmics. Now, while these are some agents that can prolong the QT interval, this list is not all-inclusive. There are some great resources online for lists of drugs and agents that can cause QT prolongation and thus increase the risk of fatal arrhythmias like torsades de pointes. But we'll list a few of these resources in below the video, but this will not be covered in its entirety in this lecture series. Due to its QT prolonging capabilities, if the patient's baseline QTc is greater than 440 milliseconds, dofetilide is contraindicated. Amongst other side effects, dofetilide can cause headache and also dizziness, very similarly to some of our other agents. This list of side effects is not all-inclusive. For a more inclusive list, I would direct you to drug information resources, but the main things to remember with dofetilide is that it does prolong the QT interval quite substantially, and it does increase the risk of torsades. Our next class 3 agent is sotalol. which, as you may have guessed from this alol ending, is both a combined potassium channel blocker and a weak beta blocker. Sotalol is very similar to dofetilide and our other and other potassium channel blockers in that it does increase the risk of torsades and thus must be initiated in the hospital setting for about 3 days, or at least 3 days. Sotalol is cleared by the kidneys, so if our patient does have a creatinine clearance less than 60 mils a minute, we are going to dose adjust. As sotalol possesses beta blocking activities, it does also cause a decreased heart rate and may also cause some dizziness, much like our beta blockers. Much like our beta blockers, sotalol also can cause some fatigue. And also like beta blockers, which we did not mention earlier, but I'll mention now, this goes back to your pulmonary sections as to how this happens. But beta blockers can actually cause some bronchoconstriction. So this can lead to some shortness of breath. And this is dose related. How this happens is there are, as you remember, beta 2 receptors present in the lungs, and at higher concentrations, even selective beta blockers will start to inhibit these beta 2 receptors. Beta 2 receptors, of course, normally lead to bronchodilation and easier airflow into the lungs, but in the presence of a beta blocker, that can cause some bronchoconstriction and can worsen some conditions such as asthma. Our next agent you don't need to know much about, but it's ibutylide. Interestingly, it does not require dosage adjustment in renal or hepatic impairment. And this only has one approved indication, which is the rapid conversion of atrial fibrillation or atrial flutter to sinus rhythm. Other than this agent is fairly similar to our other classic potassium channel blockers, and it does confer an increased risk of arrhythmias such as torsades. And our last class 3 agent is dronedarone. Now, as you may see from its name here, dronedarone, it is very similar to amiodarone. Although interestingly, dronedarone, unlike amiodarone, does not have any iodine, and this was developed on purpose to hopefully get rid of some of the side effects from amiodarone, and the hope was that dronedarone would have a lower side effect or a smaller side effect profile than amiodarone. Unfortunately, this design idea did not exactly pan out how researchers had wanted it to. As dronedarone, this is very important to remember for this medication, in heart failure and in permanent AFib. And this is, of course, atrial fibrillation that cannot be at least permanently converted to sinus rhythm. So a patient can be kept in permanent AFib with some sort of rate control, etc., that is outside the scope of these lectures. But these patients with heart failure or permanent atrial fibrillation, we actually see an increase 2 times the risk of death. As such, dronedarone is not generally a preferred agent and is especially not used in patients with these conditions. In addition to this, dronedarone, like amiodarone, does undergo hepatic metabolism. So in patients that do have a reduced liver function, especially severely reduced liver function, we do not use dronedarone. Finally, in patients treated with dronedarone, we do see an increased serum creatinine. And this is in actually about 51% of patients. So quite prevalent. And this increase in the serum creatinine can be about 10% increase. Our fourth and final class of von Willems class of antiarrhythmics are our calcium channel blockers. These are going to behave very similarly to beta blockers and will make most of their effect down here in the pacemaker potential. As we remember, calcium here is responsible for the phase 0 depolarization in the pacemaker cells. If calcium channels here are blocked, this depolarization is not going to happen as rapidly. So much like with our beta blockers, we're going to see a slower rate of depolarization, thus overall slowing the heart rate as well as conduction through the AV node. This will, of course, have very similar effects on our cardiac EKG. So here, our actual conduction velocity through the ventricle is not affected. Our repolarization here is not really being affected. The main thing we're affecting is the heart rate, or the R to R interval, the time between QRS complexes, as well as, because of the slowing effects in the AV node, it will also prolong the P to R interval and will result in an EKG that looks a little bit like this. As we see, very similar to the effects that we see from our beta blockers. Our two agents in this class are verapamil and diltiazem, which, as we remember from our hypertension lectures, are non-dihydropyridine calcium channel blockers. So these are, of course, different from other calcium channel blockers such as amlodipine or nifedipine, which are our dihydropyridine calcium channel blockers. The only ones that are antiarrhythmic in effect are the non-DHP calcium channel blockers. Both medications are metabolized by cytochrome P450-3A4, CYP3A4, and thus both drugs do have drug interactions. We will not discuss specific drug interactions, but make sure if you see verapamil or diltiazem on a patient's home medication list or a patient's medication list in general, make sure you are checking for drug interactions, especially because of this CYP3A4 metabolism. Of note, diltiazem tends to block CYP3A4 to a slightly lesser degree than verapamil, and is generally associated with a lower decrease in blood pressure, thus leading to its preference over verapamil for arrhythmias. As both of these drugs are hepatically metabolized, we do want to exercise caution in hepatic impairment. And generally, these agents do have very similar side effects to our beta blockers. So they can be a cause of orthostatic hypotension. They do cause a decrease in the heart rate, can cause bradycardia, AV blocks, etc., which will be described more in depth in the next lecture. And due to the effects on calcium channels, they can also cause some constipation. As I'm sure you remember, calcium channel blockers, these non-dihydropyridine calcium channel blockers, are contraindicated in heart failure. And specifically heart failure with a reduced ejection fraction. As we remember, heart failure with reduced ejection fraction is a pumping problem. The heart cannot pump enough blood to the rest of the body, unlike preserved ejection fraction, which is a filling problem. As calcium channel blockers do decrease the amount of calcium that is entering the cell, or at least prolong the period at which the calcium is entering that cell, they do lead to a decreased contractility, thus exacerbating this pumping problem in the heart. As such, these drugs are absolutely contraindicated in heart failure with reduced ejection fraction. This slide just gives us an overview of all of the classes of antiarrhythmics that we've talked about, and we're just going to briefly review which of the intervals we're really going to see changes in with administration of these antiarrhythmic drugs. Starting off with sodium channel blockers. As we said, sodium channel blockers prolong this conduction period, which is happening during the QRS complex, during the ventricular depolarization as we're looking at here. So we're going to see an overall widening of this QRS complex, which we will write right up here. Beta blockers and calcium channel blockers are overall going to slow action potentials in the SA node and AV node, overall leading to an increased interval between contractions, an increased R to R interval, as well as an increased interval where the signal is held up in the AV node, thus prolonging the P to R interval. And finally, our potassium channel blockers. As we see, these potassium channel blockers are going to prolong repolarization, thus prolonging this QT interval. These are very important as these are easily recognizable changes in the EKG, and I especially want everybody to pay attention to this QTC interval for the next lecture. We'll just finish up our talk about some antiarrhythmic drugs with a few miscellaneous drugs that do not fit into the other categories that we've previously described. The first of which that I want everybody to be familiar with is digoxin. Digoxin is interesting in how it works in that its mechanism is through inhibition of sodium-potassium ATPase. Now, I don't need everybody to memorize exactly the function of sodium-potassium ATPase, but overall, inhibition of this leads to increased intracellular calcium, which can thus increase contractility of the heart. For these reasons, digoxin can be useful in heart failure, as it is going to increase the cardiac contractility, thus improving symptoms of heart failure, especially with reduced ejection fraction, as this is a pumping problem. Digoxin's antiarrhythmic effects are separate to this pathway, in that digoxin increases vagal tone. So we'll do a brief review of how this works. This is a brief review back of physiology or even anatomy. But here in the brain, we have the beginning of the parasympathetic nervous system, and this nerve that we have right here is called cranial nerve 10, otherwise known as the vagus nerve. Cranial nerve 10 is part of the parasympathetic nervous system, as we mentioned, and will thus release neurotransmitters, acetylcholine, onto the SA and AV node, as we see here, and overall lower the heart rate and slow conduction through the AV node. It is by this mechanism, stimulation of the vagus nerve, that digoxin is able to have its antiarrhythmic effects. As we just mentioned, due to these effects, it does cause a decrease in heart rate and can cause some AV nodal blockade. The other really important thing to remember with digoxin is that it has a narrow therapeutic window. And digoxin levels are therefore drawn in patients that are taking digoxin to determine the dose. Well, this is not something I will expect everybody to remember for this lecture. Some symptoms of digoxin toxicity, when digoxin may go above the therapeutic concentration, can include many nonspecific symptoms such as nausea, vomiting, visual disturbances, which may present as halos or yellow blurred vision, sometimes lethargy, and then, of course, the potential for life-threatening arrhythmias. These life-threatening arrhythmias, as we'll talk about in our next lecture, are generally due to the dysregulation of calcium handling that digoxin can cause. Our next miscellaneous agent is magnesium. The mechanism of magnesium is poorly understood, or incompletely understood. But generally, magnesium, by increasing plasma magnesium concentration, this leads to regulation of calcium handling, and thus this can treat proarrhythmias caused by calcium mishandling in cells, including torsades de pointes. In addition to this, as we just reviewed, digoxin can cause some dysregulation of calcium handling intracellularly, and as such, magnesium can also treat digoxin toxicity. One main side effect to note for magnesium is that in overdose, magnesium can cause muscle weakness. And our final agent that we'll talk about today is adenosine. This agent is very short-acting, and I do not expect you to know all of the mechanism in depth, but in general, it binds to adenosine A1 receptors. This ends up blocking inward calcium channels, and therefore can lead to a near complete AV nodal block. This, of course, we can understand as calcium is necessary in the AV and SA nodes for the initial phase 0 depolarization of the cells. So something that's a very potent calcium blocker can actually nearly completely block the AV node. This can be particularly important if you have, this will be reviewed, of course, in more detail in further lectures. But this can be particularly useful if we have multiple areas in the atria firing very quickly, sending signals down to the AV node and then into the bottom ventricles of the heart. This can lead to a very high heart rate and many types of arrhythmias. Adenosine can be effective in that its administration can actually come down and block signal transduction through the AV node almost completely, thus preventing these signals from being propagated to the ventricles. I just wanted to finish up here by saying that I understand that that was a lot of information. The main thing I want you to understand from this lecture, though, is just the main ideas. I want you to understand how a sodium channel blocker may change the cardiac action potential, the fast action potential, what effects that may have on the EKG. Same thing for potassium, calcium, and beta blockers. If you don't remember everything for every single antiarrhythmic, that is okay. Just generally try to remember which antiarrhythmics fall into which classes, and I really want you to be able to determine what effects those will have based on the effects that blockade of certain ion channels has. So if you understand these main core concepts, and then which classes each antiarrhythmic fits into, that will set you up for success. So thank you so much for taking the time to listen to this lecture, and I will see you all in our fourth and final lecture, just on some very basics of arrhythmia pathophysiology.